I'll start with dosing. So in clinical practice, we often deviate from sort of the dosing and schedules that were validated, if you will, in the randomized controlled trials that led to the approval of these regimens for use in practice. And we often titrate it really to the patient's frailty, but we don't just do that at sort of baseline or when they start. We monitor their frailty and their symptoms and follow up to see if that initial hypothesized regimen works. So often lenalidomide will be reduced from its standard intensity that was recommended in the trials. If, for instance, a veteran is frail or on the frailer side, so that we see if we can get that disease control sort of benefit at a lower risk of sort of the toxic benefit. And we've had plenty of patients that have even themselves said, Doc, I know my myeloma is under better control, but I feel a lot of fatigue. It really going into the third week of treatment, which is the sort of the typical Revlimid-based dosing, 3 weeks on, 1 week off, and then 3 weeks on again. Veterans will tell us that they're not feeling well. And there's a few 90-plus-year-olds, those approaching the century mark, that have even expressly said, living, as long as I can is important, but actually my quality of life is even more important to me right now. And working closely with Dr. Munchie and other myeloma docs and clinicians in our practice, we try to titrate to just get the right balance of quality of life versus disease control benefits. And so we'll often go lower on the dose. Now, notably, we didn't look at the dosing in this study. We were simply comparing the triplet versus doublet regimen. So it's difficult to map out over all those years all the different dosing changes that are occurring in our population. But we did get an objective sort of measure of 3 versus 2 drugs, which is more intensive versus less intensive. And in fact, I think that's what we often do in frail patients, even though we're using a 3-drug regimen, which for whatever reason, either due to the drug synergy between Revlimid and bortezomib, or just the better, more effective control of myeloma with more drugs, we're often dose reducing or modifying the schedules within those 3-drug regimens. And that I think will continue to happen. In terms of the route, well, a lot of medications in oncology in general, but certainly myeloma, are switching from an intravenous or subcutaneous route to oral regimens. That's much more convenient for, say, younger patients. And generally true, I think, for older patients. However, there are different challenges. And this is where the nature of frailty, I think, comes into play. If you have a cognitively impaired veteran or a patient who is having difficulty adhering to these really complicated schedules. I mean, I think I would have trouble remembering, I have to take this pill every day for 3 weeks, and this is my week that I'm off. And then I have to remember to call in to the clinic to make sure that I have no symptoms. You're free to prescribe me the next round of treatment. And by the way, I have to show up every 2 weeks or every 3 weeks to the clinic so that they can draw my labs and everything. That can be very challenging for cognitively impaired older adults, which is quite prevalent. In our moderate severely frail patients in this study, about 25% of them had dementia or cognitive impairment. And we often will capture that when we notice that there's a challenge in them being able to fill and adhere to their complicated myeloma regimens. So I would say the route is very important. We'll actually prefer sometimes more IV or sub-Q route recommendations, just because we can confirm in some of our older cognitively impaired patients that they're actually receiving the drug. But that, I think, is another area of research that is important to look at, the challenges in and of themselves of having these different routes of administration.